Morning, audience. Welcome to another episode of Monitor Your Health, the program where we educate the public on contemporary health issues. Today we'll be talking on asthma. Asthma is a very important topic for us. The name asthma started from a Greek word, which means panting. In 1990, about 183 million people suffer from asthma. As of 2015, based on available record, about 358 million people suffer from asthma, and roughly about 397,000 people died from asthma worldwide. Now, majority of these people that died are from Africa, from developing countries. And the main reason is because of the way we diagnose, the way we treat, and the way we monitor these cases. Today, we're going to talk more about, asthma. And with me, I have studio, Dr. Olaleye Oginni, who will be, throwing light to this topic. You're very much welcome, Dr. Oginni.
Thank you very much.
Okay, so please, can you introduce yourself to the audience?
Okay.
Can you look at your speaker or the phone, something? I can't hear you from my side.
Oh.
Thank you so much. Can you introduce yourself to the audience again? Sorry about that.
Right, okay. So my name is Dr. Olaleye Oginni, and I trained in Boston University. Before I moved to the now currently study practice. I currently work with
All right. Thank you so much for the introduction. I hope the audience they can hear us clearly. So we want to talk about the condition called asthma. What does asthma? What is asthma actually? What is asthma?
So asthma is a condition that affects the airway. What happens in people with asthma is that you have a narrowing of the airway. When you breathe, it goes through the lymph node, and it goes through the then divided into small branches in the lung field, and from there it goes
Dr. Oginni. Dr. Oginni, sorry. I think we're having issues. I thought it was only from my side, but there are a lot of comments on the portal. They can't hear us. They can't hear. I think they said the audio is quite poor. They can't hear. I can't hear either. I was just trying to figure it out. So can we just have a look at the sound from your end? I mean, can you hear me clearly?
I can hear you clearly. I can hear you quite clearly.
Now, I don't.
Let me know if I'm breaking up and you can't hear me, but can you hear me now?
Very, very clearly.
Excellent. Okay. So I was describing what asthma is. So I said asthma is a condition that affects the airway. So in a normal person, when you breathe in through your nose, it goes through the windpipe, which is called the trachea, and then it goes into the lungs. And then when it gets into the lungs, it gets divided into different branches of small pockets, which we call the bronchioles. And then from the bronchioles, then it goes into tiny air sacs, which we call the alveoli. And from there, it diffuses into the bloodstream, from where the oxygen then goes into the red blood cells to travel around the body. In someone with asthma, the narrowing of the airway happens in the bronchioles, so in the lung field itself. So it's not from the nose, it's not from the windpipe, it is in the small pockets of the airway in the lungs. where there's narrowing of this airway, and then you struggle to get the oxygen around your system, and then you have more breathing difficulties. You have to work hard to breathe, and then you can occasionally have what we call a wheeze, which is like blowing air through a narrow pipe, and the sound that it creates is called the wheeze. So because the narrowing of those small pockets make the movement of oxygen much more difficult, and that's what we call asthma.
Right, thank you so much. So basically, it's a form of, reduction in air supply into our system due to the narrowing of the airway. Okay, thank you so much. So how does this present? How does it present? How do we know that this person, one person or the other, have asthma? Because so many people suffer from this disease, and I think there are a lot of issues where people do not even know that they do have it. So how do they know? How would it present?
Yeah, very good question. So the symptoms of asthma, the most common symptom will be what we call cough and wheeze. Those are the two most common symptoms. So when you have a cough that is varied at different times of the day, usually worse at night and worse first thing in the morning. And then when you have what we call a wheeze, which is that sound that you get when the narrowing of the airway occurs and you're trying to get the air to move through them. So those are the most two common symptoms. But other symptoms, obviously, when the airway is narrowed, then you get breathless, so you have breathing difficulties as well. And then the other thing you can have is what we call chest tightness. So it's not a pain, but it's tightness. You just feel like somebody is pressing on the chest wall and that you are struggling to get enough air. So you have a sensation that you're trying to breathe and that you're not getting enough air in your system. So a lot of people with mild asthma, because asthma could be mild, moderate, and severe. So when people have mild asthma, they may not even know because they don't usually get the symptoms often, and they probably only get it when they exert themselves. So, when they do running or, activities that increase, the amount of oxygen that they should get, and that's when the narrowing of the airway occurs because they cannot cope with, the increased activity. So that is what we call exercise-induced asthma. So asthma is quite common, like Dr. Femi has already mentioned. You have probably 1 in 10 people as in children. 1 in 10, children would have asthma, but a lot of them outgrow it as they grow older. So it's less common in adults than in children. So in adults, you probably have maybe 1 in 20 people with asthma because half of them have outgrown it by the time they become an adult. So when you have a child who's always having a cough, or and they checking him and they're saying he doesn't have an infection in his chest, and the cough seems to be more at night, think about asthma. Think about getting him diagnosed for asthma.
Right. Thank you so much. So now the audience will be hearing this and they feel, okay, so most times, are there some other things that might be, related to these symptoms other than asthma in children that they need to be mindful of before they now go to the doctor and then start clamoring diagnose asthma.
So in terms of, we need to look at, like you rightly said, so cough is a common thing. There are a lot of other reasons why a child would cough. So, viral cough is quite common, which is not asthma. You can have a cough of a chest infection, which is different. But when you have a child that has recurrent cough, yeah, with breathing difficulties and wheeze, especially if there's a family history of asthma, then that is highly suspicious or suggestive of asthma. So we need to then think of what are the triggers, what are the things that can trigger asthma. So any viral infection can trigger. So someone with cough and cold, if a normal person who doesn't have asthma have a cough and cold, they just have a little bit of a cough, runny nose, and they get over it. But if somebody that has asthma, underlying asthma, has that, that can trigger an asthma attack in them, and then it goes into their chest and gives them a wheeze. Another thing is pollens. Pollens may not necessarily be that common in our part of the world, in Nigeria, but it is something that can trigger asthma attack. So exercise is one thing I mentioned earlier. So if you have a child that gets breathless when they're running around with their mates, they're playing around, normal activities that kids would do, and then they get more breathless than everybody else doing exactly the same thing, then that's when you start thinking, could this be asthma? They get breathless and they start coughing at the same time. Other things, like there are some medications, aspirin, anti-inflammatories like ibuprofen, and even medications used for other things like what we call beta blockers, like propranolol. They are triggers for asthma. Common triggers include things like pets. Some pets, fur that comes from pets, dogs, cats that we keep at home, sometimes might trigger asthma attack in some people. So you find out that, they may get, more breathless when they come near some animals and pets and, than other times. And one key factor is the variation in their symptoms. So it comes and goes at different times, especially if it is worse at night. Other things could include, even for adults, pains, some certain chemicals and pains, that you inhale can trigger asthma attack in some people. And then we have a very, very, very common inevitable thing, which we call house dust mite. So it is present everywhere in your household and it is inevitable. You can't escape it. So, but in some people, unfortunately, this can trigger asthma attack. And interestingly, memory foam, which is good for your sleep, it gives you comfort. Some materials that are used in making the memory foam can trigger asthma attack in people who are predisposed to it. So what you need to think of is if there is an episodic, so the most common thing is that it is episodic, so it's not there all the time. So if it's an episodic cough and wheeze or breathlessness or tightness that you get when you get exposed to certain things, and that it improves when you're away from those things, then you need to think about asthma.
Right. Thank you so much. Now, so we now have a situation where somebody now knows that they've got this conditions, being or they feel that they have this condition, and they're wondering, so am I gonna get it confirmed? How do I know that I actually have asthma? What will you advise the audience on this, please?
So the best thing, if you have any of the symptoms that I've highlighted above, the first thing to do is to speak to your doctor. And the doctor will take a good history to understand the events that leads to this and how often it happens and all the rest of it. Take a family history as well. And then the doctor may ask for some tests to be done. So there's what we call a peak flow meter, which is blowing into a small sort of, it's like a pipe that measures how fast, you can blow into how fast the volume of air that you can blow into that thing can be. So there's a certain level that is expected for everybody, depending on your age, your sex, and your height. So it is measured for each individual. There is a standardized expectation. So for people with asthma, no matter how strong you are, the level that you will blow into it, the volume of air that you blow and the speed at which you can do that will be reduced. So that test, it's very easy to carry out and it is readily available. So your doctor can give you that peak flow meter and say, take it home with you and then check your values in the morning and the evening and do it over a length of time, for example, like 2 weeks. So if you do that, they may notice that there is a knock, there is a dip at early morning. So they can say do it first thing in the morning and later in the day. So if you do it first thing in the morning, sometimes you realize that your value is lower at that time than the one you do later in the evening. The other test is called a spirometry, which is the more what we call a gold standard test or very common test. In doing can you hear me? Hello? Right. Okay. So can you hear me? Are you there? Can you hear me? I think you're on mute. Can you hear me? Right. So, like I said, The next test to do is what we call a spirometry. Yeah. In the spirometry, there are two types. It's also blowing into something. So there are two types that they check for the spirometry. One is how much air you can blow into it in 1 second, and then how much air you can blow in one breath. So there are two different things. In 1 second, how much air can you blow? What's the volume? And how much air can you blow over a whole breath? And then they use that ratio, which is called the FEV1 over FVC, to check what is expected, and that can help you in the diagnosis of asthma. For adults and children who can do the other tests, the National Institute for Health and Care Excellence, which is called the NICE, issued a guidance very recently, a couple of years ago, which is another one, which is checking for the nitric oxide level, which is how much nitric oxide that can be in your breath. So that is usually used for adults, but for children, older children who can do it as well, it is a recommendation that we do that as well. So if this is available locally where you are, that is also a very good one to do. But a realistic and practical way to check for asthma is for your doctor to give you what we call a bronchial dilator. So a medication that can help to relieve the symptom. So a common one is what we call salbutamol, which is also known as Ventolin. So if your doctor gives you the inhaler and you see that when you get breathless and you use the inhaler, you feel better, then that is enough to confirm that that is asthma, which is called the reversibility test. So for example, you take the inhaler before you go to do an exercise and you feel, and then you realize that you don't get as breathless as you would do without the inhaler, then that is confirmatory that that is asthma. Or you use the inhaler and your peak flow, which is what you blow into the tiny little device that I mentioned earlier, if your peak flow is better after using the inhaler, then that is suggestive of asthma as well. So those are the two ways in which we would say a diagnosis of asthma should be confirmed. So like I said, asthma runs in family, but not in everybody in that way. So some people may not have a family history of asthma and then they develop asthma. So it's still common for that to happen. But in most people, you find out that there is a family history somewhere along the line where somebody in the family has developed asthma in the past. But because it is underdiagnosed in a lot of people, and when they grow older, they outgrow it. So some people wouldn't have known that there was a family history because their parents might not even know that when they were children, when they were a child, they had asthma. So if the child develops asthma, then they will say, oh no, I never had asthma, I don't have asthma, but they probably had it as a child as well, and they've outgrown it. So there is a family history that is common, but like I said, your child can't have asthma without a family history.
Right. Thank you so much for that detailed explanation there. So is asthma something that I can walk into my doctor and then he'll be able to diagnose it, just as I'm there? Can that be possible?
Yes and no. I say yes because most times the history, a classical history of the reversibility of the symptoms, like I explained earlier, is enough to make a diagnosis of asthma. So your doctor will have a very high index of suspicion of asthma based on the history you've given and based on the examination, especially if you have symptoms at the time of presentation. So if you go and see your doctor at the time that you have the wheeze, you have all the symptoms, and they do your peak flow at the time, and they listen to your chest, and they do all the things, they can make a diagnosis of asthma easily straight away there and then and give you the right treatment. But if you go at a time that you don't have the symptoms and you just say, oh, I get this every now and again when I exercise, with a good history, they can make a diagnosis, but they will then need to do the test that I've mentioned earlier, and those tests would then give you a confirmation.
Right. Thank you so much. Now, so having been diagnosed with asthma, how can I be treated?
Yes, absolutely. So asthma is a condition that you can control and can treat. So there are various ways to treat it. So remember I said the principle of what happens in asthma is that you have narrowing of the airways. So what you want to do is to prevent those airways from narrowing. And it happens in asthma when they become responsive. We call it hyper responsiveness to natural stimuli that other people wouldn't respond to. So when
Right.
your airway is more sensitive, you want to make it less sensitive, and you want to make it able to be able to cope with these things. So you want to prevent the narrowing, and you want to make it to open up. So you use what we call a bronchial dilator, which is a reliever. So like I said, salbutamol, which is also known as Ventolin, is a very common one that is easily available. So if your doctor can give you a trial of the inhaler and ask you to use that when you feel breathless. So if you feel breathless and you use the inhaler and you feel better, then if it's a very mild one that you don't get it all the time, that may be all you need. But if you are using the reliever, which is the salbutamol, to relieve your symptoms up to 3 times a week, then it means your asthma is severe enough to need something to prevent it. So remember, reliever is to relieve the symptom you have now, but there is another inhaler, which is called the preventer, which can prevent you from having the symptoms. So to use the commonest types of preventer, they are steroid-based preventers. So there is another type of inhaler that the doctor can give you to prevent the symptoms, and you need to use that one every day, irrespective of whether you have a symptom or not. And the way it acts is different. So it doesn't help to just relax the muscles to cause them to open. It reduces what we call inflammation around these air pockets. So because it's a preventer, if you have symptoms right now, the preventer is not what's going to help you, it's the reliever, which is the salbutamol. So the preventer helps you to prevent regular frequent occurrence of asthma symptoms. So you would need to use that, like I said, either every morning or every morning and evening. And it may take up to a week before you notice that you are getting the benefit of taking it. And in some cases, it takes up to 6 weeks before the maximum benefit is seen. So for some people, when you use the preventer on a daily basis, up to 6 weeks, you realize that you actually don't need to use the salbutamol anymore because you don't get the symptoms anymore, even when you exercise or when you get exposed to pets or other things that would otherwise have caused your symptom. You discover that you're absolutely fine. So those are the ones in which, and then there are some long-acting ones. There's another type of inhaler, which we call the long-acting bronchial dilator, which helps to cause relaxation of the airway over a considerable length of time, up to like 12 hours, rather than just here and now quick relief. So those are the types of inhalers that you generally use. But when you have an acute asthma attack, so somebody is acutely breathless right now. So the first thing is you use the salbutamol inhaler to help with the symptoms. If it's not really helping and you're still having a lot of tightness in your chest, some may have extremely severe symptoms that you're actually too breathless to talk, that you can't even talk at all. And when the airways narrow too much, then you won't have oxygen going around your system, and then you are depleted of oxygen, and that's what we call cyanosis. And in that sort of severe situation, and that person gets into what we call a respiratory distress. So they're having extreme difficulties panting. And in children, you see them flaring their nose, you see them, the neck moving up and down and the ribs moving up and down, gasping for air. In that situation, do not stay at home using the inhaler. Rush that child immediately to a center where they can be seen because they need immediate intervention. They need to be given oxygen mask over the nose to get oxygen into their system. So they need to be bombarded with more oxygen. They will still be given what we call nebulizers, which is, these inhalers are in a form of nebulized form, in a liquid form that turns into air and goes into the lungs to act more quickly. And then they will be given some steroids as well, which can be in form of an injection. which is hydrocortisone, but they can also give them in form of tablets. Obviously, tablets will take a lot longer to act, but in extreme cases, they give them the injection of the steroid, they give them the nebulizer, and they give them oxygen, and that gives them immediate, sort of relief from their symptoms. And in some other cases, there are some medications for children who have, very severe symptoms, or even some adults. There are some tablets that they take on a regular basis, which one of them is called Montelukast. That tablet, it also helps to reduce some sort of reactions that bring up asthma in a slightly different way. And that is also one of the treatments that is available for asthma.
Thank you so much. So in all this, somebody might be sitting down there that, yes, I have this asthma, and I don't know. I know they've talked about, all these, how those might talked about, cold, they talked about, but I don't expose myself to this. I try to protect myself. Is it that it runs in my family, or how does it work? So is this something that's by virtue of the fact that a family member, well, like a parent, one of the parents, or both parents, or maybe a close sibling, nuclear sibling as I did, then I have the chance of having it as well. Is that how it works?
Yes. So, it can run in families. Hello?
Yeah, we can hear you. I can hear you loud and clear.
Yeah. So it can run in families where there is a family predisposition to having it. So like I mentioned earlier, so a parent could have had it as a child when they were much younger. And by the time they grow old, they might outgrow it, but they may still even have it. But we've seen a lot of cases where there is no documented family history, and you get this sort of, symptom, especially the exercise-induced asthma. It may not be one that runs in family. And there is a type that is in young adults, which occurs when you are in your early 20s or mid-20s. That also may just be sporadic, meaning that there is no previous family history, and then somebody just suddenly develops it. So while it runs in family, we can also have it where there is no previous family history at all.
Right. Okay. Thank you so much for that. Now we're getting to the end of the program, but I think now I want us to talk. As a doctor, of course, the public will also learn from this. Now I realized that being in Nigeria, I've seen quite a number of patients with asthma asking for opinion and advice. There's the use, there's a particular medicine that people tend to believe in a lot here, aminophylline. It's one of the theophylline. And I know that, a lot of the cases, this is what we use for acute management here. But my experience, in the UK, maybe you might be able to answer this. And if not, we'll wait for one of our colleagues to also, dabble into that, and we'll have a bit of discussion. We use a lot of theophylline here in the management of acute phase. Do we know there are evidences around this? And then if we have to do a comparative, look at the way acute cases are managed. Example, in the UK, how do you go about, I know you're a general practitioner, but I know you also have a second leg in the emergency management of cases as well. So how do people go about managing acute cases in the UK? And does theophylline or things like aminophylline, does it play a significant role in what we do in the developed country? I know we have very good results, and from what I've gathered, there are a lot of people dying from these diseases here, and from this disease in Nigeria and developed countries. The majority of the mortality that we're having, 90% of cases of people die from asthma, they're from developing countries. Even though you have more people having asthma in developed countries, it's very, very paradoxical. More people develop asthma in developed countries, but more people die from asthma from developing countries where the numbers are low. And I think it has to do with managed cases. So what's your take on acute management?
Yeah, you're absolutely right. So answering the first question, the a lot more people have asthma in developed countries, but they're well managed and well controlled, such that you're on regular preventer, you're on regular reliever. So the incidence of acute severe asthma or life-threatening asthma, which are the ones that kill people, so the incidence of life-threatening asthma is significantly reduced because it is a lot more controlled. So there's a stepwise approach that we use here where, depending on how bad your asthma is, that will determine the amount of medications and the types of medication that you take on a daily basis. And then there's preemptive management, such that, people are well educated and well aware of their symptoms and their triggers, very, very important. Their triggers, what brings the attack on. So they have medicines that are readily available with them at home to take should this happen. So, and immediately they know that that's not acting and not very effective, they get themselves to the hospital and then they get a treatment. So the mortality is definitely going to be lower than where we are not well aware of the diagnosis, and the child gets the attack every time, and it is until it becomes life-threatening that they then go to the hospital. Now, going to the issue of the aminophylline, that's a very, very interesting question. And I actually wanted to mention that earlier, but I thought I would leave that out. But it's good that you brought it up. So, I practiced in Nigeria before I came to the UK, and I remember using aminophylline quite well for acute severe asthma, and it worked like magic, the patient comes to you, they're extremely breathless. You just put a cannula in and then you start doing this small push of the aminophylline, and you can see instant results. You can see them getting better within minutes. And so we know that it works quite well. But here in the UK, we do not use that anymore. In fact, that's been phased out a long time ago because of a lot of side effect profiles and complications with the medication. Evidence has shown us that there are better ways in which we can manage it here. So it doesn't play a role in the management of life-threatening asthma or acute severe asthma in the UK. So what we use here is simply SOS for the initial phase, which is S for salbutamol, which is the Ventolin, and that comes in form of nebulizers, which I mentioned, which is something that is given to you through a mask, and it goes through like a liquid bubble that goes into your nose. That's what we call a nebulizer. So you have the salbutamol nebulizer, which can be mixed with another type of nebulizer, which is called Atrovent, and the medical name for it is a pratropium bromide. So that's one. So that's the inhaler. Then you have the second one, which is oxygen. You remember I said SOS. The O stands for oxygen. So you get high volume of oxygen that you're given. I know that in a lot of developed places in Nigeria, you can have oxygen readily available, but in a remote part of a village where, maybe there is only one oxygen cylinder available and it's already given to somebody else and another person has asthma, that is realistically not going to be available at that time for use. So in that situation, they would use aminophylline, which would help, which would get the child better. But here, you give the nebulizers, you give oxygen, and then you give steroid, which is the other S. When I said SOS, steroid is the last S of it. And steroid, we use prednisolone, which will be 20 milligrams for a child or 40 for an adult. But you can also use hydrocortisone, which is an injectable form of the steroid in a severe form. And when it is that severe and that person is not responding to the initial SOS, there are other medications that we give here. And another example is magnesium sulfate, which is, more advanced than, and it's not usually the first line that you give to people. And it depends on the level of, responsiveness. There are a lot of other medications that can be given, but at that time, the person probably will be transferred to an intensive care unit, taking over, the respiration, giving hyperbaric oxygen to get them to work better and, to improve their things. But in pragmatic African or Nigerian sense of it, most of these things may not be readily available everywhere. I'm confident they are available in a lot of hospitals in the cities, but in the rural areas and the towns, they are not realistically readily available. So the benefit of using aminophylline in those circumstances to save the life of that child far outweighs the risk. So it is quite sensible when there are no other medications that are readily available to use what is affordable and cheap that will save the life of the child. So it makes absolute and perfect sense to still use aminophylline in those circumstances.
Thank you so much, Dr. Oginni. And I think, obviously, because of the time, we might not be able to go deep into this, but I still have a lot of questions I would have loved us to discuss, because when we talk about the situation that happens in the rural places, isn't it, if I have to look at it from another angle, I believe that aminophylline, for instance, is available wherever you want it to be available because the system wants it to be available. The same system that makes aminophylline available could make other people as well. Isn't it a fault of our system? Isn't it a fault from the way we've been managing our health system in this country? There's so many questions to ask, and there's so many answers that are still hanging and blowing in the air when it comes to health situation in this part of the world. Thank you so much, Dr. Oginni, for joining us today. What will be your last words, your advice to the patients and also to the governments of this country?
So my advice is that asthma is underdiagnosed. Think about asthma when you get unduly breathless during exercise or more breathless with cough at night and first thing in the morning. And if it's episodic, think about asthma, see your doctor, get the treatment. It's easily controlled, and you can live a better quality of a life by having the treatment for asthma. And it's more about creating the awareness in the general populace that this thing is there, it is there to be treated, and the treatment is readily available.
Thank you so much. So to the audience, thank you again for joining us on this episode where we've discussed. I'm sorry about the technical issues we had from in the beginning, and maybe a few in between the program as well. We're trying to make this better each time. Thank you for being here. Thank you for always being here to learn. And if you have questions, please just drop them just in the comment section. We will be picking those questions and be answering them one after the other to the government. Thank you so much for always being our lead. Thank you for what you have been doing for us in this country. Please, our health system is in shambles. We hope that one way or the other, we can find ourselves, we can find our ways, we can find a track through this jungle that we find, ourselves. There are a lot of gaps in things that happen in terms of management, care, not only in asthma, in so many areas. But, what suffer is the life of people, the people that you govern. And then we pray that God will give you the direction, that we know where to go. We can have a system that we can put in place to make, simple system to save lives here and there, one thing or the other. Thank you for always being there. And on this note, I want to say, have a good weekend. And then we'll be seeing you again next week when we come with another interesting topic. Bye-bye. Have a lovely